Happy to facilitate that session with Dr. Kagashi. So without further ado, Dr. Agashi, I'm leaving the floor to you to please go ahead and present the experience of Tanzania. Please go ahead.
Can you hear me? Thank you, Simone. Good afternoon, good morning. This is Dr. Margaret Kagashi working with the Tanzanian Commission for AIDS, first actually leading the HIV prevention portfolio. So I'll be taking you through just for less than 7 minutes to 8 on what we're really doing in Tanzania in terms of addressing the stigma and discrimination on the KP programming. Next slide. So just to highlight key points on these slides, just to take for the team to take notes. Despite of everything, but Tanzania is cognizant of the importance of the KP in controlling the HIV epidemic, which is the good point from the country level. If the policymakers, the decisions makers knows that KP are controlling the HIV epidemic, it is very crucial. And as a country decided to approach the situation in public health approach, covering everyone who needs services must be given that services. And that is actually looked at in terms of client-centered and vulnerability-tailored interventions. When we say vulnerability, we look at who is more vulnerable, where are the more risks, the incidents. So the evidence-based interventions are targeting which typology at what time, in which geographical positions. So also the services are being provided voluntarily, respected and friendly. I will see on the next slide. Non-judgmental, no discriminatory care, target hotspots, area with high-risk individuals. We know we can't find the KP cannot just come in the facility because they're not sick. It's just they need services in their respective area. So also ensure safety of client. Also the KP services, let's take note on the KP services integration into the general health system. So it's there. But even though we offer the verticalized part of the services, basically we look on the specific needs of the client, and we say this is client-centered. Their KP needs more for mental health. Their KP need more legal issues, all that. So it is integrated in the health system. So they are recognized in the general health system, but they are vertical, which targeted specifically for this population. Next slide. On this slide, I just wanted to highlight, we provide the differentiated HIV services for the KP, and we are targeting what service to bring, who should provide those services, where we should provide those services, and when. This is stipulated clearly in our DSD guidelines, which are targeting the KP interventions in country. So I know we provide services according to the HIV SRH issues. We provide HIV testing, prevention. We have biomedical, behavioral, and structural. We have care and treatment, but we also have other services like legal, rehabilitation, and mental health issues, depending on the KP needs. So who providing those trained healthcare providers? We may not be reached the 100% of being trained on KVP-friendly services, but we train that we recognize this is KP-friendly services facility. Also, we have the lay cadres who provide services, are the most critical people reaching the KP population in Tanzania. So KP peer educators, community health workers, volunteer expert client are the one we are using to make sure this the population is being reached. But we also have other cadres, as I said, we provide other services like legal and mental health. So where we provide, we have health facility-based, but we have community services delivered, like hotspot area, mobile clinics, tents. These are the areas where they can get services. When we provide those dependence on the needs of the client, as I said, this is client-centered. So during normal working hours, we provide extended hours needs, but we provide weekdays, also weekends, at night, during the night, during the day. So depending the preferences of these clients. So we have this moonlight testing and all that. So this is just a summary of how this has helped us to make sure the services have been reaching the community we are targeting. And my last slide, next slide. We just need to take a couple of minutes to look at what is really happening. I've already said what are we considering as the health approaches, what are the key issues in that health approaches, what are we looking at? But I categorized the experience of addressing stigma in 3 categories. 1, the enabling environment, but we needed to have community engagement and empowerment. So we had also to have oversight and coordinations. These are the area just categorized to make sure it may not fall like when we're done with this, we go, but these are the things we do practically we are doing at this point in addressing stigma and making sure we reach the targeted populations as required. The first thing is we have existing policies and guidelines, actually, which stipulates how services to be provided. We had HIV policy, which states the provision of service to everyone, doesn't discriminate anyone. Everyone needs to actually be reached with services. Also, we have stigma strategy, which has been reviewed last year, 2023, which has a component. It's a general KP stigma strategy, but it has a component of KP within it, which actually says they need that services too. So we have national KVP guidelines, which are using to provide services, where to provide, who to provide, what are the minimum package for a KP, all that have been in the KVP guideline. Also, we have KVP training package, and SOPs are the standard operating procedure, which guides the facility, the communities, the providers. How do we provide services? To who do we provide the service with all the guidelines? But as I said, we have the DSD guidelines, as I provided highlight on the last slide, showing how the DSD is being operated in Tanzania in terms of KP. Also, we have the health strategic plans, which actually explain the general HIV, including the key populations. When we talk about HIV, the KP team is actually it is a priority population in that area. So in enabling environment, another issue we are looking at is human resource for health, because you cannot provide these services if you have not trained the human resource, or you don't have human resource. So we have categories of human resource. We have healthcare providers who are already trained on KVP-friendly services, and stigma and discrimination using the total facility approach. For those who know, this approach was introduced in 2018. So this is we are using this training to make sure the total facility approach has been an indicator to use to train the healthcare providers on stigma and discrimination. Also, we have KVP, peer capacitated on demand creation, interpersonal communication, linkage, and referral. As I said on the DSD party, the peer or the communities themselves, they need to actually, they're the ones who are the key players on service delivery to the key pop. So we are capacitating them. We have a training package targeting the peer and community providers. Also, we provide services in terms of his facility and offering also the outreach services. Also, we have health management information system ready. These are the enabling environment, because you can provide services. If you don't record anything, how can you say I've reached how many? So we have the system already. This is health, also non-health at the same time, just lacking the word non-health. So we have KVP, many framework indicators are there. DHIS is recognized the KVP. Also, we have a unified community now system, which takes the client level data from condom use, and other services have been provided. Also, we have the TOMSHA. which is the community, typically community, including stigma and discrimination being picked up in this M&E system. So this is the enabling environment I'm referring to at this point. So when we go to the community engagement and empowerment, Tanzania has a KVP forum. This is typically the KP constituents. They oversee over 120 the civil society organization and the community-based organizations. So they are overseeing, actually, they are KPs themselves, they're overseeing the KP-led organization. If you need to work with the KP-led organization, you need to reach this the KVP forum, which is legally there and approved by the Minister of Health and Tanzanian Commission for AIDS. And they have 2 seats in that forums, which we recognize they're there. So we are working with them in everything we plan, we design, we do with the KVP forum. Also, recently, we were able to develop the Community Violence Prevention and Response Committee, which addresses all the violence targeting the KP. These have been developed from the regional level to the district level, to the village level. So we have these communities now, Community Violence Prevention and Response Committee. These are developed just to address the violence part of every KP, which actually been faced with any issue of legal and other being criminalized or put into jail without any reasons or because they're KP. That is where this Community Violence Prevention and Response Committee comes in. So this has been approved by the National Multi-Sectoral KVP Subcommittee, which include the KVP representative within the. Also, we have
Dr. Kagashi, I'm just cognizant of the time, and I wanted really to open because this is really amazing work. So I don't know if you have more to go, or we could just open for questions and answers.
This is the last slide I have. That's the only one.
Okay, great.
But probably my last word should be that we have also the oversight and coordination mechanism. This is very critical. This one chaired by the Prime Minister's office, but is co-chaired by the Ministry of Home Affairs, the police commissioners. They are part and parcel of that, the National Multi-Sector Committee. Even though we have the different typology of the KP, which have the seats in this, the National Multi-Sector KVP subcommittee. So these are the main key issues on addressing and making sure that the services are reaching the targeted population.
Thank you. Thank you so much. I think this has been an amazing and very comprehensive response to the stigma and discrimination. You've really cited everything that is supposed to be in a very solid program. And I wanted to make sure that we also give room for the participants here to say what they think. What is really happening? Are there any questions and answers? I would like to open the floor. I see Jabwil, do you want to come in and speak to this thing you're mentioning in the chat?
Oh, good afternoon, colleagues. I'm Jabu from South Africa, from the National AIDS Council, also overseeing the key populations program in the country. And I'm interested to learn more about this KVP forum that has been established by Tanzania, and to understand why it would sit under the Home Affairs sort of ministry instead of health. I think I'm just interested to learn more about that. Thank you.
Thank you, Jabuli. Do you have another question before maybe Dr. Margaret, you want to take that one until other people come on board?
Okay. So there's difference between the KVP forum and the National Multi-Sectoral KVP subcommittee. These are the different bodies. The KVP forum is typically only the KP people leading that in country. But the National Multi-Sectoral is a subcommittee which include different ministries. So because we know actually the HIV is not health issues, it contains multi-sectoral approach, so it cannot sit in the health sector. It sits in the multi-sectoral ministries, which is actually the NAC, the Commissioner for AIDS, which actually coordinates every HIV interventions in different organizations in different areas. So that is where, so the KVP forum is typically for KP only. They're the one who leading that. We're just members, just 2 members of the government have a seat on that. But otherwise, they're the ones who runs the forum.
Excellent. Thank you so much, Margaret. I think we have also another question from the floor on CLM. How have you, to what extent it's been leveraged? He says the presentation is silent on CLM. I know you mentioned employing CLM, but maybe more on that. And then there is a question on how is this PPR resourced? How funding goes into that?
Maybe I can assist to
Yeah,
answer on the chair. Yeah, Marin is the chair of Tanzania. Yeah, sure. Marin is the representative of Tanzania Chamber of Profession chairperson. Actually, this year for COP23 year one, PEFA had approved 300,000 for KP specific CLM, where this will be coordinated by the KVP Forum. So we started by preparing tools for KP specific, and this process was approved by the government. So KP-led CLM is being conducted, and now we are in the process of starting data collection. Thank you.
Thank you, Marinus. That's really excellent. So back to the question on how is the VPR resourced? And I see another question. Yeah, go ahead.
The VP resource for VP, yeah. So we actually PEFA also approved about 300,000 for VPR, and we started engaged with the government on first to approve of the VPR, I mean violence prevention response, which is the crisis response mechanism. So it was approved, and now we have started reviewing tools that will be also incorporated in the DHSS tool. So this VPR actually together hand in hand with CRM also monitors human rights violation, monitors implementation at health facilities, as well as VPR. So they're just kind of two activities that are going together, and through VPR, I think we can come out with issues that could be addressed and done advocacy at national level, particularly on the policy issues. Thank you.
Thank you so much. I mean, we are running into closely to time, but there are two questions on what the key Ps are when you mention key Ps, and also if you can provide some success stories on the violence part. Maybe if we don't manage to answer that, we could always, like ask you, Margaret, and the team to be providing that later on. But these are the ones that we've seen. I don't know if you can come quickly on that. You have 3 minutes, 3 seconds or something. Do you want to come back quickly on that?
On the KP?
Yeah, which KPs and any success stories on the violence?
So actually the violence is, we started.
Productive health and rights service, as well as other healthcare service they may need. It is crucial that everyone has equal access to these services, regardless of their sexual orientation or gender identity. We must work to eliminate any barriers that may prevent individuals from accessing the service that they need. Our mission to lead on enabling sexual health and rights of LGBTQ+ people and diverse sexual orientation and gender identities. It's important to provide comprehensive people-centered and friendly service on sexual health, social protection, and human rights advocacy. By doing so, we can advance equality and equality in society and to ensure that everyone has access to the care and support they need. So in our approach, we utilize and key population-led health service model. It's called KPLHS, which I will explain to the next slide, at Impulse Foundation. And we empathy a human rights framework to promote stigma and discrimination-free service. Target populations, men of sex, men, transgender people, young key population, people living with HIV, sex workers, people who injecting and using drug, and also people who are still in the prisoner. And we are so grateful for our collaboration from PEPFAR, USAID, EPIC, IHRI, Institute of HIV Research and Innovation, Bangkok, Global Fund, Department of Disease Control, National Health Security Office, and also Thai Health Promotion Foundation. Next slide, please. Impulse Foundation provides service to help reduce stigma and discrimination because Stigma individuals face internal and external stigma, including self-stigma and public social, professional, and institutional stigma. Service providers, there is a lack of understanding to gender sensitivity and sexual orientation, leading to stigmatizing attitude and discrimination. The third one, service availability and accessibility. There is a lack of need-based and client-centered service, as well as a need for space and create a friendly, non-judgmental atmosphere. Issues such as limited service hours, days of operation, and transportation option also contribute to difficulties in access to the services. The fourth one, health service system. Non-Thai clients, particularly undocumented migrant workers, lack access to health insurance scheme within the current system. And the last one, legal challenges. Unfavorable laws regarding sex work, drug use, and migrant workers, harder access to service tailored to the need of these vulnerable groups. How M+ Foundation provides service to help reduce stigma and discrimination by implementing the key population that helps service KPLHS model under reach, recruit, test, treat, prevent, and return. Here is how they do it. The first one, KPLHS model, create a safe space to help provider and counselor from the key population who have a deep understanding and empathy of sensitive topic. Second, reaching and recruiting clients through activities tailored to group interest and need, such as sports, contests, and online platforms. And the third one, minimizing loss of case by retaining individual in service. For key feature of the approach include providing people-centered friendly service and non-judgmental, and to implementing a non-discriminatory policy, integrating one-stop service within the same day. We offering HIV and STIs, hormone testing, same-day prescription for PrEP, PEP, and ART medication for both treatment and prevention. For our stigma and discrimination campaign and public advocacy, M+ has been doing since mid last year. For example, U equal U literacy and say zero. Stop Steak for All campaigns, anti-bullying toward LGBTQ+ students and community members. What action do we need? No one left behind, more inclusive. Get to know and understand what is U equal U. Next slide, please. Among community health workers, for internal training staff, annual stigma and discrimination training. We do e-learning from Department of Disease Control and UNAIDS to address gender intersectionality. Gender and intersectionality is a term used to explain an idea that various forms of discrimination, such as those centered on race, gender, class, disability, sexually, and other forms of identity that do not work independently, but interact to produce particularized form of social oppression. Internal training at M+ for everyone, including the cleaner as well. How do you address intersectionally in the workplace, like said before, or nationality, religious, job position, political affirmation, or even mental status. So that way, we can create a more inclusive environment for everyone to recognize intersectionality and different stages of the employee life cycle. Continuously review your policy, process, programs, and initiative. The third one, actively seek different perspective and feedback. Fourth one, to build a functional DEI dashboard. And the most important one is self-help for both of us to do some sort of live self-education and up to date. And after that, we share the information and discuss about this again. Talking about
to interrupt, Kunray, there's 1 minute left of the presentation.
Okay, talking about external training, we create structural stigma and also the HR management with the code of conduct of staff. For S&D free service, code of practice for staff, we create SOP for all HIV service. Once a year, we got a review and renew and up to date about S&D by M+ staff and under FHI 360 usage and PEPFAR. Once every year, we do assessments for both the service quality in community and service quality in facility. The most important one about the challenges for stigma and discrimination policy code of practice, it's only for key population people who live in HIV, key population target, but other example like Hunan, KPL, HIV migrants, undocumented, and people, even people in the community still lack of knowledge, and talk about what is S&D, HIV/AIDS literacy, and they still believe most of LGBTQ relate to HIV/AIDS, including drugs and sexual. Female people who have left behind because migrants without document using substance, work in sexual entertainment, intersection identity, address vulnerable and behavioral rather than group, strengthening system of health, and plus also working on the goal and philosophy of theory start from ourselves first. That means every single staff have to know and balance between quantity and quality, practicing on self-awareness, mindfulness, spiritual improvement, moral behavior, attitude, belief, and respect. Nevertheless, the most powerful impact and still happening, that's a big challenge for us. From nowadays, I believe is the social media is a big impact to the society. Example like social media news, billboard, misinformation about HIV/AIDS, and they're still doing in the same way, with the same words, characterize, bully, panic, or making fun of us. What we are doing now, and plus now create more activities, campaign, media production, skill contests, bring more self-esteem, or inside out for key population and for all, especially to young people, to create more challenge and capacity, more workshops, speak up about themselves, sex education, what is harm reduction, strengthening automatic negative attitude change. And we will keep doing, we will never give up to create more acceptance and equality, inclusive education, non-discrimination policy, human rights campaign, equal right for LGBTQ individuals, public awareness and reducing gender stigma, promoting awareness and problem management, protecting rights and problems resolution, developing non-stigmatizing model, equal literacy and project. This is all representation from M+ Chiang Mai today. If you have any further questions, feel free to ask. Thank you very much.
Thank you so much, Kunray, for such an exceptional presentation and overview of the work that, and the really important work that M+ is doing in Thailand. We haven't had any questions in the chat, so I'm now opening up the floor. We'll have time for 1 or 2 very quick questions. So if somebody has a question, please raise your hand. In the meantime, I have a question for you. And
yes,
so,
for sure.
As part of what M+ is doing, the services that you're providing to reduce stigma and discrimination, you mentioned campaigns and public advocacy and the Stop Stig campaign. I wondered if you could tell us a little bit more about that campaign.
Yes, talking about a Stop Stig campaign, we got support from the Thai government. It's called Thai Health Promotion Foundation. We target the audience to the young kid population, and also including the general population, people living with HIV in young age. The 4 main points of this Stop Stick campaign is to public awareness and reducing gender stigma. We educate about on HIV prevention, human rights, sexual diversity, to reduce stigma in relationship. And also we promoting awareness and problem management, support awareness and problem for those who infect and affected. The third one is protecting rights and problem resolution by developing mechanisms to protect rights and resolve issue and make sure the effectiveness at the community level. The last one is developing non-stigmatizing model. We create non-stigmatizing models and practice generate data for scalable implementation in different regions. And we not just do in the community in the city, we also across to the rural area, to the school that's kind of like never reach out to us. And we keep doing this every 3 months to the same school.
Oh, that's wonderful. So we only have about 30 seconds left. So we may get cut off. I want everybody to join me in a thunderous virtual round of applause for Kun Ray. And while we're doing that, perhaps you can say, if you had one piece of advice for other organizations about addressing stigma and discrimination, in 10 seconds, what would that one piece of advice be?
I would definitely say attitude, you know, because like I said, I have to like start for myself, and also the attitude. If you have like a fundamental of mindfulness, self-awareness, and also like the dignity of spiritual things will work well. And also it's it's also like it's keep me stigmatized and discrimination free from that.
That's wonderful. And I think we're at time. So everyone, please thank me. Join me and don't thank me. Join me in thanking Kun Ray for such an amazing presentation. I expect that we're going to be called into the big room now.
Thank you so much, Khop Khap.
And I believe that your slides will be available to anybody who is interested, and that you're also really happy to take questions about the work that you're doing and that M+ is doing.
Right. And also for further information, the last slide, I have like an email and contact. You can reach out to me and I can, give the feedback and answer. Thank you.